I've worked in HIV for many years, and I think at the beginning of the epidemic, HIV was a disease that killed. Opportunistic infections, tumours, really quite a horrific disease. But then with the advent of highly active antiretroviral therapy, we've really been able to control HIV, and with the development of new drugs, perhaps a clearer way of thinking on how to treat, when to treat, what not to do, we've really been able to have fantastic results, and morbidity and mortality from HIV has been dramatically reduced. Nowadays, people expect a normal quantity of life, but they still have issues, and one of the major issues really worldwide, both in the resource-rich and resource-poor world, is that as we control HIV, other infections which the patients are harbouring in the long term are causing problems. This particularly is reflected by both hepatitis B and hepatitis C. Worldwide, hepatitis B and indeed hepatitis C are both far more prevalent than HIV. They occur in the same geographical areas, they have the same risk factors for acquisition, so it shouldn't be surprising that many of the patients living with HIV are also living with hepatitis B or hepatitis C, or indeed both viruses. Hepatitis B is a treatable infection. It's unclear whether it's really curable. Certainly in the context of HIV that may not matter, where the first choice of treatment is going to be a tenofovir-based regimen for that co-infected individual. Tenofovir continues to show excellent results when used as a nucleotide with other drugs, and so by using tenofovir in the long term, we are able to control hepatitis B viral replication. However, still many patients, indeed the majority of patients, remain e-antigen positive if they commence with e-antigen, and the chances of actually getting rid of surface antigen is very, very low, even over a prolonged period of time. Therefore, individuals are still going to be at risk of relapse if they fail tenofovir, although resistance has not been reported in hepatitis B to tenofovir, but patients may fail their HIV drugs and be inadvertently switched away. And also there continues to be the risk of hepatoma associated with the presence of hepatitis B virus. And one of the big mistakes which is made, I think, in HIV care is that individuals aren't appropriately monitored for the development of hepatoma with hepatitis B. But hepatitis B tends to be a relatively easy disease to treat. What about hepatitis C? Well, hepatitis C has been a bit of a problem, especially in recent years. We were actually the first people to report the epidemic of hepatitis C acute acquisition in men who have sex with men. I think when we first reported that over 10 years ago, no one really believed it was going to be a big problem, but it now is a global issue. In HIV-infected MSM, and indeed we've recently reported at ICAC that this is now becoming much more prevalent in HIV-negative MSM. So it may be a problem outside of HIV, but because of this acquisition of hepatitis C, that's led to many more patients having long-term infection, and with long-term infection, the potential to pass this virus on to others. Globally, again, if we look at resource-poor areas, again, because of the similar routes of transmission, the similar geographic areas of high prevalence, we see a lot of co-infection. So it's not only an issue for the resource-rich, but also the resource-poor world. Treatment's been pretty disappointing. We've had pegylated interferon and ribavirin with reports of perhaps 25% of genotype 1 patients responding. Genotype 2, 3, perhaps 50%. But more recently, we've had the development of DAAs, which have become used in HIV and recommended to be used in HIV co-infected individuals. First of all, we had telaprevir and boceprevir. We showed similar results to the HIV-negative population. Now, with the advent of interferon-3 regimens, there's great excitement amongst the HIV population about getting their hands on these drugs, although it's difficult because of the cost. But if we look at the results of treatment with DAAs, as regards interferon-sparing regimens in an HIV-positive population, the results of clinical trials are at least as good as in the HIV-negative. So I think in the future we're going to see a rollout of these treatments into the HIV-positive population with what I feel will probably be better results than the HIV-negative population, because the HIV-positive patients have already shown their ability to adhere. They have an undetectable viral load and therefore have shown that they're going to take these medications. One of the big issues, however, when we come to choose between DAAs is going to be drug-drug interactions. We're lucky in some ways that we have a great deal of expertise, not only as physicians, but perhaps mostly as pharmacists. We have a great deal of websites which are dedicated to this, where we can actually look and change drugs around, and we're not going to make the mistakes of drug-drug interactions either preventing treatments from working or leading to excess toxicities. So we're going to have to be careful in the future in the HIV population, because some of these drugs, Sameprovir may be a good example as a protease inhibitor, which really has a lot of drug-drug interactions with HIV drugs. But then again, we have other agents such as Sofosbuvir with limited, if any, drug-drug interactions. We're also going to have to choose our HIV drugs very wisely. We're aware that our HIV medications such as raltegravir, rilpivirine really have very few drug-drug interactions. So again, it's going to be balancing the HIV treatment with the hepatitis C treatment. I think if we look at the future, there's a lot to be done. We're talking about hepatitis B and curing patients in the future. We're talking about the eradication of hepatitis C. I think most importantly, all of this is going to cost money, and we have to be aware that we're going to have to invest heavily as regards money into these drugs which certainly work. And in the long term, this will translate into cost effectiveness with great quality and great quantity of life for our patients.